some of you who have just arrived will not have heard that there's a little bit of overlap between the end of the board meeting that's going on confidential business, and that is being steered by Anne Tutt for the last couple of items which relate to the committee that she has chaired. We have already with us myself, Gavin Screeton, I can see, has made it, and Claire Flint. The reasons why Claire and Gavin are able to hear is that the remaining bits of business have potential conflicts of interest, and we're very careful in our private business about even the potential of conflict of interest, and therefore they were exempted from the final bit of the business.
Jonathan, can you hear me?
We can hear you. Thank you, Anita. Can you hear us?
I can only see myself in a tiny square in the right-hand corner. I can't seem to get myself onto the screen.
Do you want? Well, you're on my screen. You're not tiny on my screen. Right. That's okay. I don't think you need to see yourself large screen, Anita. I think the important thing is that we can see you. I can only see myself small in the corner, so I regard that as a bonus. But
right, okay, fine, thank you. Understand.
The system is designed to work that way, Anita.
So, can I start then with known apologies? I don't think Giles Bond-Smith is able to make it today. Neil will have the full list of any others. I have apologies from Bruno, Sam Foster and David Wallaker. I hope a number of other board members will make it once their business is finished. I can see some people joining now, so very welcome to my board colleagues. It's clearly more efficient in the board when I leave than when I'm there, so I shall learn from that. We have, I think for the first time, Joy is with us. Joy, have you made it yet? I can't see. When she does, I'll just invite her to say hello. And we have a number of new governors. So Sally Ann Watts, Mike Gotch, who's just arrived, I think, Nina Robinson, Gemma Davison. This is all the first full meeting as governors. And we also have our Deputy Young Governor, Mariam, with us. I wonder if those people would just like to say hello so that they pop up on people's screens. Mariam, would you be able just to say hello and introduce yourself?
Yeah. Hi, I'm Mariam. I'm 17 and I'm part of YIPI, which is the young people's organisation at the JR aiming to improve young people's stay at the hospital.
Thank you very much. You're very welcome. It's great to have you with us, Mariam, and please don't hesitate to flag up if there's something you want to hear about or want to say about. I'll do my best to keep an eye on your raised hands and on the chat function, but if I miss it, somebody else, I hope, will draw it to my attention. Nina, do you just want to say hello?
Hello, I'm Nina and I'm delighted to be here. Thank you.
Mike, are you with us now? Mike Gotch? I saw him arriving. Maybe he didn't manage to stay in. Sally Ann?
Yeah.
Hi, I'm Sally Ann Watts, newly publicly elected governor for Berkshire, Buckinghamshire, Wiltshire and Gloucestershire.
Welcome to Sally Ann. And Gemma, is Gemma here?
Hello everyone, yes, I'm Gemma, for Governor for Cherwell. Nice to meet you all.
Welcome. Mike, do we have you on the call now? Okay, I didn't see, I saw Mike arriving and maybe his connection failed. It's hard to keep track of everybody. Joy, do we have you now? Okay, I think we will stop trying that. And Joy has already said quite a lot during the board meeting we've had during the day, which has been her first board meeting. And I know a number of governors attended that, and all of you will be able to see the recording when it comes through. I think those are probably the key housekeeping elements. And I thought it would be quite useful just to open the meeting with just a little bit of an update on where we are in relation to COVID. And I'm just wondering whether Sarah Randall is on this call or not. Sarah, are you on the call?
Yes, I am, Chair.
Would you just like to give us a flavour as you briefed me and Bruno briefed the board early on, just on the where we are in relation to the COVID? Because I know a number of governors are concerned to understand the rates of infection in the community and the impact it's having on our hospital and staff.
Yes, so for those that you don't know me, I'm Sarah Randall, Chief Operating Officer. So I think last week, colleagues may be aware that Oxfordshire as a whole has been, in particular Oxford City, has been put on with additional support with the number of COVID cases that are rising in the community. And we've got some additional government support in terms of testing the population. So we're about fifth nationally with the highest number of COVID symptoms at the moment. In terms internally, if I just give you some key sorts of things that have been happening here. So between the 9th and the 20th of May, we had 0 admissions for COVID this year. And that was really the first time that we've had 0 all the year. The number of patients that we potentially see within our emergency departments at the moment is around 5 per day, with around a couple of admissions per day. I think we've been, as I think many of you know, we've been putting the numbers actually on the website as part of all trusts have been doing the numbers of COVID inpatients and COVID attendances on our website. So those are the numbers at the moment are quite low within the organisation, but we know that they're primarily of the Delta variant, which is seen as the national picture. At the moment, we've got no significant impact on our electives, but we do have a number of staff that are off in terms of self-isolating, looking after family members, and or have COVID. So we are in a different position from where we were in the wave 1 and wave 2. I think the colleagues will be aware that we've had some refurbishments of level 5 particularly. So we're cohorting a lot of these patients into those refurbished areas. We've got additional side rooms. The length of stay in some patients is a little less, and we've got a number of patients that are on what we call level 2 oxygen levels. So we're just in for oxygen, and we've got a couple of patients within ICU. So we're seeing a slightly different picture than we saw, obviously, at the beginning of the year. So vaccination is important, and that's what we're making sure. And I think Megan was going to join us and potentially chair if she was going to talk a bit about IPC guidance. I don't know whether that'd be helpful.
Thank you. I'll perhaps turn to Megan in a moment. Do that. This is important context for us. And when we picked this up at the public board this morning, Gavin, I think you made an observation about the pandemic not being over, and I just wondered whether you wanted to share the thoughts on that. I'll then go to Megan about the infection control, and then I'll throw it open for questions, because this is obviously a really important context, and a number of governors had asked for some information about this. So Gavin, I think we don't believe we're at the end of the pandemic yet.
No, Jonathan, I think colleagues will be aware from listening to the news what's going on. I mean, there are clearly going to be many millions of infections in the country over the next few weeks. Hopefully the majority of those will be mild, but there's clearly going to be a significant increase in the disease. I think the idea of herd immunity, which is rearing its head again, in my view, is a mirage. I don't think we will ever reach a situation where there is herd immunity like there is, for instance, with measles, where when you reach herd immunity, the disease cannot really take hold in a population. I think we know from the past that immunity to coronavirus is fleeting. So we get our seasonal coronavirus, our cold in the winter, and we get it again in 2 years' time, and all the rest of it. So that's obviously happening with this coronavirus. The the ability of vaccines to actually completely protect against infection is nowhere near 100%. There is a report from Israel with the Pfizer vaccine, which suggests that only it has an efficacy, that is preventing infection, of only 65% against the Delta variant. So really the hope, so we're going to see a lot of infections of people who've had the vaccine. The hope is that the vast majority of those are going to be mild, not require hospitalization. And I think this is just a sense of what's to come. This is clearly not going to go away, hopefully. What will go away is the large successive waves that hit the NHS as the thing becomes more endemic. But the idea that vaccines will prevent the disease and make it go away, I think, is a mirage.
Thanks, Gavin. And up until about a fortnight ago, we weren't seeing much impact in the hospital. We're beginning to see it now. I'd like to invite Meghna to talk about the infection control principles. And then I have a number of governors, starting with Tony, who've raised hands, and I'd like to give people a chance to discuss that. Before I do, I'd just say welcome to David Clayton-Smith, the chair of the ICS, who'll be with us for a bit later on. David, we're going to let this just update on COVID run a bit, and then I'll try and bring things back so you can bring your agenda item forward.
No problem. Okay, thank you.
Meghna.
Thank you, Chair. So having heard an update from Sarah in terms of how many patients we currently have in the organisation, and from Gavin in terms of the numbers increasing, which they will increase, and Oxford being one of the highest, Oxfordshire and Oxford City in particular being one of the highest in terms of the numbers of COVID infections. There's been an enhanced response in terms of testing available to those between 18 to 29 years of age, and that's being provided until the 18th of July at least, and that's various places within the city. In terms of the hospital, nothing changes. So our infection prevention and control guidance remains the same as it was, which means everyone must continue to wear masks within our hospital premises. We will continue to focus and work with our staff and partners on making sure that there are no face-to-face events arranged in the organisation. Where possible, there will be virtual meetings. There has to be a specific reason to have a face-to-face meeting, which has to be agreed by the events committee. We will maintain our focus on hand hygiene and on the personal protective equipment that is available to our staff. We will continue with the same arrangements for the personal protective equipment. And in addition to that, all staff who work on aerosol generating procedures will be fit tested on 2 separate types of FFP3 masks. We will continue to distribute the Clinell wipes across the organisation and make sure there are screens where required if there is more than one person, depending on the occupancy of the room, which is being determined. All our staff have been risk assessed, which is also important, and all staff are encouraged to continue to access the lateral flow testing devices and report into our system on twice weekly basis. And our staff testing for symptomatic staff, of course, continues and is available.
Thank you very much, Meghna. I pulled this forward partly because some of our members were a bit late coming, and partly because colleague governors had asked for an update on that, and it seems really pressing. And Tony, your hand went up first, so hand over to Tony.
Thank you very much, Jonathan. I have 2 questions, if I may. The first one really relates to who is getting the virus, and secondly, of those getting it, how many are serious? It just seems strange that we've got such a ramp up suddenly when everyone thought that the vaccine was going to contain it.
So if you look at the Oxfordshire statistics, and there's a briefing that the County Council puts out, which is a shared briefing across partners, you can see that it's young adults who are predominantly catching the virus, and of course most of them are at least not double vaccinated, possibly not even single vaccinated. It's spreading across the county, so it started off in the city, but the rates have also begun to increase on the outskirts of the city. We are also seeing, though, some more cases amongst the older age group as well. So it's not confined to them, but that is where the sort of main picture is coming. That's what I pick up. Megan and Sarah, I don't know if there's more to say than that.
That's exactly it. Thank you.
Gavin? You're on mute, Gavin.
It's absolutely right that the burden of infection is with younger people. But I'm not sure about the numbers in OUH, but nationally, there are a very significant number of people who have been vaccinated in hospital who are in older age groups. So the burden of severe illness is likely to be going forwards in vaccinated elderly people, and obviously unvaccinated elderly people. That's where the burden will be.
Okay.
That's a sobering thought for us, and we need to think carefully about it. In terms of the data, we're looking at whether or not we can just give you a regular fortnightly or so briefing just on the data. It is around on the Oxford County Council websites and others, but it's not easy to find unless you know where you're looking. So with support from Caroline, we'll just think about how we can just summarise that and get it round to governors regularly. Tony, does that answer the question that you had?
That answers that one. The second one slightly different. Mention that the staff are still testing. Some of those are testing positive. My understanding is that the government is going to allow medical staff to not have to self-isolate if they've been in contact. Is that going to be acceptable to you? And is that going to then increase the amount of staff you've got available?
Meghna, can you pick that one up? Because we're already piloting that sort of approach, aren't we?
Thank you, Chair. So there has not been any national guidance about medical staff not self-isolating at the moment. That is being considered. Having said that, we are part of a Department of Health and Social Care trial, which is limited to very few hospitals in the NHS at the moment, where if our staff are contacted by the NHS app, then they need to report into the COVID staff testing service, where they are appropriately risk assessed by one of our team. And if that risk assessment is low, then they are allowed to work with daily lateral flow testing and additional PCR tests during the week. It does not apply to household contacts because the risks from a household contact are much higher.
Okay, thanks for the clarification.
Thank you. Cecilia.
Thank you, Jonathan. I just was just really with local knowledge. I was talking to a partner, GP partner, in a large health centre in East Oxford. They had great success with vaccination at the beginning, once they got, but now they've hit a real wall of reluctant patients who are not willing to be vaccinated, despite all efforts, and it's jolly difficult to reach these people. Thank you.
Thank you. That's noted. Stuart?
Thank you. I just wondered how far the Trust was engaged yet in the booster and/or flu campaign that is talked about for the autumn. Is that something that's beginning yet? Planning for that involved, and what's the timescale, do you think, for that?
Megan, was your hand newly up on that?
Thank you, Chair. Stuart, thank you. We have been informed that the boosters for the COVID-19, so vaccination, will begin nationally in September. So we know that the program will begin, and the recommendation is that healthcare workers should have the COVID vaccine and the flu vaccine at the same time in either arm. What we don't know yet is which vaccine. So what's not been decided is who should have which. So if you've had a Pfizer, do you get a Pfizer? And if you've had AstraZeneca, do you get AstraZeneca? So that's not been decided yet. I don't know if David is on the call, who is our SRO for vaccination, but essentially David and I are working with our teams to organize our program, because the flu program has actually been most successful with ward vaccinators. However, if we have to get everyone onto a different site to give the COVID and the flu vaccine, we've got to think about 2 different ways. So we are planning our way through that.
Thank you very much.
I don't think we do have David. I have Jonathan Wyatt, and then I have Anita. Jonathan, you're on mute at the moment.
Okay, I'm there.
You're there, thank you.
Some 15 years ago, I dealt with a case in an arbitration that involved the SARS virus. The expert evidence provided me said that the SARS virus had a predilection for the Asian genome. Do either the present standard virus or the Delta virus have a predilection for any particular genome? The second question, which really revolves from the standard virus, did it come from the Wuhan laboratory? And is the Delta virus a change from that standard virus, or a separate secondary virus which may have been pumped out from the laboratory? And again, which genomes do both these viruses have predilections for? Does anybody have any info on that? That's all.
Thank you very much, Jonathan. So I think the Wuhan question is probably above even Gavin and Meghna's pay grade to resolve at this stage.
I'll have a crack at them.
Okay, off you go, Gavin.
So Jonathan, I'm interested in the comment about the SARS virus having a predilection for the Asian genome. I don't think that's true. I think we would all go down with SARS. God forbid if it came along and it was, quite frankly, a lot worse than SARS-2. In terms of is the Delta variant a derivative of the original Wuhan strain or a brand new jump into man? It's a derivative of the original Wuhan strain. There are thousands and thousands of different genomes circulating, just as you would expect, and just like you see with many viruses like HIV. In terms of whether or not this was a jump from an animal into man, or whether it was a jump from a virus, perhaps from an animal, cultured into a laboratory and getting into man by mistake, or alternatively, was it an engineered virus? As you know from the press, that is causing quite a lot of heat at the moment. I think for me, there are probably 2 possibilities. One is it came from straight from an animal, which would seem to be by far the most likely. However, it is conceivable it was being cultured in a laboratory and escaped from there. So I would have thought those 2 were the most likely. I think the idea that it is a completely man-made virus is less likely. Whether we're ever going to know the answer to these things, I somehow doubt. But I think the balance, the most likely thing is it like SARS, jumped straight from an animal into man.
Thank you, Gavin. There can't be many Foundation Trust governors meetings that are able to have quite that conversation, and I'm going to discourage following it too much further. We do know that the virus affects some vulnerable communities more strongly than others, and we've taken particular concern about risk assessing staff from minority ethnic communities, but quite why that is, Jonathan, perhaps is for a different session. I'm going to move to Anita, and then I have Jules, and then I'm going to try and move us back to the more normal. Anita.
Thank you very much. you've not made thus far two questions. Much mention of the state of the Horton in relation to Cherwell. I read on the various documents that come out that the numbers of people who are COVID inflicted are quite high in the Cherwell area, i.e. North Oxfordshire, therefore the Banbury area. And I'm wondering, is the Horton Hospital similarly coping? And, you know, nobody's mentioned that. And if I was to ask to go on a visit at the Horton, might that be reasonable? Or what's the state of the situation for North Oxfordshire, and particularly the impact on the Horton Hospital and its staff? Have all its staff been tested, for example?
So, Anita, I'll let Sarah answer the question about the Horton and visiting and the like. The Cherwell was very high in infection rates a few months ago. It's now a bit calmer and it's not so different. The big spike has been around the city, but as I mentioned earlier, it's expanding out. So it's very possible that Cherwell will get affected highly again, but it's not currently the hot spot. But the hospital bit is Sarah's territory. So I'll pass to Sarah for that.
Thank you.
Hi, and thank you. The Horton Hospital is managing with the COVID numbers as we've got at the moment. We've got allocated areas to look after those patients, and they're not under pressure, particularly of an increase in COVID patients. What we are under pressure, and you might well aware of, Anita, is that the numbers coming through our emergency department on both sites is quite increased, and that's a slightly different answer. So we've got an increase in attendances at both emergency department, which is also a national picture. I think as in terms of coming onto site, we have still got, as Megan has said, our IPC guidance in place, making sure that we wear masks. You know, as all viruses, it's transmissible, easily transmissible. So making sure that we're washing our hands and adhering to all our infection prevention guidance is really important. So, and we need to take extra vigilance.
There is, of course, a very high percentage of people from South Asia and other parts of Eastern Europe who have settled in the North Oxfordshire and South Warwickshire areas. And therefore, the nature of the population going into the Horton is not a particularly well educated in terms of what's currently happening in the UK, either because of language issues or whatever. And I just wondering how the staff at the Horton are coping.
Go on, Sarah.
Is that something that Terry wants to? The staff are coping well. I think you know, we're making sure that we've got an internal programme, as you're aware of growing stronger together, and that ensuring that our staff we've got wellbeing leads, and making sure that they've been rested, with reflecting and recovering our staff. Obviously, at the moment, we're ensuring that we've got everybody having their regular annual leave, so which is really important.
Yeah.
And making sure that we've got that all in place, and making sure that we've got support in terms of their own particular well-being by departments.
So would it be reasonable for me to ask to go on a visit of the Horton, or would that confuse matters for them?
I think that would not be a good idea at the moment, Anita. We're restricting visiting in order to protect people, and when we are in a position to reopen that, we will let
them. And then my second question is, are you satisfied, or do you believe that all governors have been tested and been vaccinated? Or, you know, is that an issue which the Trust wishes to involve itself with? Or is it a matter totally that we must initiate this for ourselves? What is your comment on that?
So, Anita, it's not our job to choose whether you get vaccinated or not. It would be our concern, if we were talking about reopening visits, to make sure that we were risk assessing those appropriately. But you should have been invited to be vaccinated through the normal system. That wouldn't be something we were doing through the Trust. I think that's right, Megan. If you haven't been offered a vaccination, Anita, please don't say that now. That's personal information, but perhaps we could have another conversation. I need to try and move on. So I have Jules waiting, and then I'm going to try and go back to the agenda. Jules?
Yes, thank you, Chair. Just a quick question for Meganat. Do we know if there's any national plans following on what Cecilia said? You know, if they come into ED or outpatients and they disclose they haven't got the vaccinations, will we have the facilities to give them while they're within our trust?
So actually we do that for flu, don't we? So
Yes.
so actually if we have access, then absolutely. But the problem with the COVID is the storage, the COVID vaccine. So you can't have it around on ward areas. But in terms of the booster, you know, we will need to look at opportunistic vaccination.
Yeah. Thank you.
I think you've got to wait, haven't you? Don't you have to wait a few weeks to give it?
Between the flu and the COVID?
No, sorry, following a COVID illness, don't you have to wait?
At least 14 days of symptom-free period, Gavin.
Yeah,
I thought Jules meant people who didn't have COVID but hadn't been vaccinated.
Like if they come to outpatients, because I don't know if we routinely ask them or if they come in when they break their leg or something. Well, I thought if we had them in our bed, we could jab them as well.
With consent, Jules, of course.
Yeah.
Oh, of course.
Okay. Last thing before I move on then, I just wanted Terry to have an opportunity just to confirm that the support for staff at the Horton in terms of well-being, you know, is the same as we offer for the other sites. Terry?
Yes, please.
Yeah, I can confirm that, Jonathan. Now, the Growing Stronger Together programme and the R3P is offered across all of our sites, and the psychological medicine team have reached out to the Horton as well.
Good. Thank you. Thank you very much.
Okay, thank you very much, everybody. I feel slightly vindicated by allowing a bit of space for that at the beginning, because there clearly were a lot of issues that people wanted to raise, and we'll think about how getting that core information across more regularly for people. With your agreement, Governors, I would like to move to item 4 and 5, item 5 and 6. So that's the discussion of the future while we have David with us, and then go back to some of the more routine housekeeping things afterwards, because the council asked on a number of occasions to improve its understanding of the way in which the integrated care system is beginning to develop. We've had James Kent come and talk to us a couple of times, and David Clayton-Smith, the chair of the ICS, is aware of the questions that a number of people have asked about how we integrate governance at the ICS with the governance of organisations, and how we get good public and patient involvement in decision making. And we're very pleased, David, that you've come to join us. We had planned to sort of have a broad discussion about the bill that's before Parliament and the sort of general issues. We've circulated to governors the NHS providers briefing, but I think in light of the discussions we've been having, my suggestion is that we give you the floor or the microphone or the video, whatever the right phrase is, just to talk a bit about the way in which things are shaping up in your mind, and then open it up for discussion. Are you comfortable with that, David?
Yes, that's fine, Jonathan. Very happy to do that. And well, thank you very much for inviting me to join you this afternoon. I know I've met some of you, but I haven't met others. So very briefly, I've been independent chair of the ICS now almost for 2 years. And actually, in your previous conversation, we'll see how we've managed to fill in the time between starting this and actually getting towards trying to restructure. Before I came here, I was chair of an NHS trust in East Sussex. I've sat on the board of Frimley, which of course is an FT. I am currently the chair of the Academic Health Science Network for Kent, Surrey and Sussex. And back in the day, so it does feel a little bit circular, I was chair of a PCT when we transferred into Ccgs. So seen a few of the changes. I imagine that what I'm going to run through might be familiar to a number of you. So I'm trying to get that kind of balance between not telling you stuff you know, but actually telling you enough so we can shape the conversation and shape the questions. Of course, the most recent change of Secretary of State has meant there's some minor adjustments to the bill, some in terms of what we're calling boards and committees, and I've tried to make those adjustments. So I hope I've only got really 2 slides to run through, and I think I'm going to be assisted with that. And I hope the information is helpful, and I hope it sort of increases your depth of understanding. But as Jonathan said, I'm very happy to join in answering questions as they come up. Is it possible to share my slides?
Neil, if you've got the slides ready.
I have the slides. I'm just about to share now.
Thank you.
Thank you. And actually, Neil, we can go straight to the second slide. Can everyone see that okay, or can we make it any bigger? Or?
Can you put it on the slideshow, Neil? You might need to. I think you'll need to click enable editing first, and then you'll probably be able to do it. Now try slideshow.
Well, don't worry if you don't. We can.
Doesn't seem to want to go, does it?
Sorry, I'm not sure why that's not working.
Okay. Try the View tab and go into Reading View. That normally increases it. We may have to work with this, David. I'm sorry. I don't know why Neil's computer is so sluggish. It must belong to the trust.
Not to worry. Anyway, I'll run through it, and I hope people can see enough on this. Integrated care system are not completely new idea, and there are other places, obviously, around the globe that are working on them.
We're seeing your screen, not your share now. That's better. Now we have what we should be seeing. David.
Okay, oh, there we go. Oh, marvelous. Very good. Integrated care systems, if you think about the nature of population and the length of time we now live and the amount of health and care issues that we need to be addressing, being able to put the working of those more closely together is a kind of obvious thing to do. So an ICS is designed that a health and care system can work effectively together. And within the Bob integrated care system, we have 3 places. So Berkshire West, Oxfordshire and Buckinghamshire. And there's some 4 very clear responsibilities that the integrated systems are given. And the first one is to improve population health. And I mean, this is not about patient health, it's about population health. And of course, at one level, we'd be very happy if people didn't become patients, because they obviously remain in the community and not requiring to come into hospitals or into community facilities. But it is about population health, and therefore it spans all the way from prevention through to rehabilitation, through to the areas of social prescribing, loneliness, communities and how they work. So it is aimed deliberately for that breadth of activity. The second one is improving outcomes for residents and patients. This is important in a sense. The residents and patients is really the point I've just been making, but the improving the outcomes is not about measuring how much effort we put in, it's about measuring the benefits that we get out of it. And I think that's very much a shared sort of metric for all participants, all providers, that we are looking at how much difference are we making and what are the outcomes. Better value for money, this really isn't a cost issue. Well, we will be under cost pressure because health systems always are, but this is about making sure that the care pathways and the nature of the care that we give are providing best value. So it might mean that we need to, if we look at things with greater breadth, it may mean that we need to change the way that we construct our care pathways and how we undertake those activities. And if you think about The difficult area really on prevention, because it tends to be a bit longer term, is better value to intervene early than to have to put in remedial action when it's kind of too late. And the wider social and economic development, we are very large employers in all the communities that we work, and how we work and how we impact on the environment. And, you know, less outpatient appointments mean less car journeys, which mean better quality air. So there is, if you like, opening our eyes up to be a very important part of the communities and economic systems that we work in. What I've tried to do in this next section, and this is the bit I've updated the title slightly, is to go, so how will it be organised? And the bill that's going before Parliament talks about having an integrated care partnership. Board, forum, who knows, but an integrated care partnership. Now that will have membership from the Integrated Care Board, and I'll come on to that in a minute. Obviously local government colleagues and others. And others is a very broad church, if you like that, because the responsibility of this group is developing an integrated care strategy for the whole system. So you can see how the voluntary sector, how all sorts of providers, users, getting the information from carers, and all of those have got to find their way into the process that can produce this strategy. Now, clearly, not everybody can be in the room at the same time, so we have to develop a fairly effective kind of network for making sure that dialogue works. And I'll come back to that in a minute. The next board is perhaps slightly more conventional in as much as the Integrated Care Board, which has a very much an NHS focus, is about if you like, delivering the plan. So making sure that we've commissioned, that the quality of care is what we want, that the finance is balanced across the whole system, that we're addressing inequalities in the various communities, and importantly, that the move to integrate and to transition into a fully integrated care system is kind of vested in this board. Now, the membership of the board, it's interesting. This is one of the things that's changed slightly with the bill going before Parliament. But clearly there will be executive members, and a lot of the ICS team will be there. There will be partners, and in the previous incarnation of this, it talked about having at least one partner representative from the acute service, from primary care, and from community providers. That's changing a bit, but it is not yet settled. The presence of non-exec directors. Now, clearly, the independent chair is non-exec, but within the previous iteration, there was a requirement for 2 completely independent NEDs, who were not therefore part of any partner organisation, but were going to be there, one to chair the audit committee and the other to chair the remuneration committee. I quite favour some independent NEDs, because I think it's quite useful to have that kind of mirror put up for us, just to check that we're not getting too kind of internalised. But I think we're going to need more NEDs than that. So the legislation talks about being permissive, which is a sort of balance between, well, it'd be quite helpful to get the guidance, and the guidance for this latest iteration is due out end of this week, beginning of next week, we're told, and allowing us to be able to shape these boards in the way that suit us. So, for example, Bob has 3 places and 3 very distinct local authorities. If you go to Surrey, they have Surrey. And so you can see that we do need the flexibility to make these changes to suit our own particular configuration and geography. Now, the important area for those 2 top boards are going to be statutory. So you can see, therefore, why quality of care finance and audit chairs and all the kind of things that really you'll be familiar with an FT board are going to have to be contained within it. But most of the focus and activity is really going to be at place. So, you know, Oxfordshire will need to create its own plan. And so there will be place-based partnership boards, and these won't be statutory boards, and they can be configured slightly differently. So the Oxfordshire one and the Buckinghamshire one don't necessarily have to look the same. It is likely they will be encompassing a local government. It likely obviously will be the NHS, and this is going to be much more the kind of the partners within the place itself and the geography. Health and Wellbeing Board and the role that plays is important. The voluntary sector and so on. And I won't list out the and so ons because I'm bound to forget somebody. But they've got to be manageable boards. These are not sort of big conferences. This is a manageable board who will have to develop a plan which will then have to be delivered in place. And the Integrated Care Board will be responsible for the delegation of money, but also the delegation of decision-making rights will go from the statutory board out to the partnership boards. Now, the partnership boards can have a number of different forms, and I won't go into them, but there will be a mechanism by which the Integrated Care Board can actually delegate responsibilities down to place-based. And then when you talk to place-based people, they go, well, that's fine. But actually, what you need to do is to get down to a lower level to really think about localities. And so the configuration of the primary care networks and the sort of community end of local government will also kind of need to be working together, and they will have a relationship mainly with place-based boards, but of course they can be involved, as they are in the vaccination program, with activity which would run down nationally and through the region and down to ICS. So one of the questions that I've been asked as we've been sort of moving towards this is, well, okay, David, you tell us what you're going to do and tell us what we're going to do, and we can get on with it. And I think that this is the wrong way of looking at it. Because if you think about the vaccination program and you think about the Department of Health or the NHS, and you think about the regional office, and you think about the ICS, and you think about place, and you think about your trust, and you think about the PCNs, we've all, with our local government colleagues as well, we've all had an important and additive role on the same topic. So I think we've got to start thinking about this in this connected up system way, rather than sort of slicing up bits of responsibility and working in a sense like we've always worked, but now I just know the bit I'm doing. So I think there'll be some changes there. And if I could have the next slide. Thanks very much. I've just made a few little notes here about NH trusts and foundation trusts. I mean, clearly you remain statutory bodies within all this. There will be a duty placed on the Integrated Care Board to meet system financial objectives, and that essentially will be financial balance, both in revenue and capital. So there's this sort of balancing act across the system, not just to fix the finances, but when you think about the value for money, is to make sure that the money we have got, we are spending in the most effective way. And broadly, the NHS providers with the NHS, you will retain your organisational, financial, statutory duties, but in the planning, we need to be working together at place and at system. And of course, with your trust, you're also working outside the system as well with the broader reach that you've got. So we've got to be intelligent about that kind of multi-layered approach to managing the resource. It has been said in the bill going forward that NHS England can impose capital limits on foundation trusts if the system is at risk. So let's just see what that really means. But it does suggest that if you've got a Rolls Royce at one end and a kind of rusty heap at the other, you've not done it properly. So there will have to be some kind of intelligent view across the system to make sure that we're investing in the right place and providing those services. So the Integrated Care Board will be the focus for that kind of NHS provider planning. I think what I'm saying here is that the better we work as a system, the better that we plan and participate, there will be less need there'll be for people to feel they need to come in from outside to kind of interfere with that. But the previous work in the paper that you probably saw within the design framework talked a lot about provider collaboratives. And there will be, I'm sure, provider collaboratives. It's quite interesting that the headlines of the bill that went in is quite quiet on provider collaboratives. But I mean, Jonathan and I have been involved in conversation with colleagues across the system, and certainly the exec team and Bruna have as well. And there's real merit in thinking about ways in which part of your business can be done better by working with colleagues across the piece. The final bit, just to kind of finish off here, is so what are the immediate challenges? Because this is a 3-5 year program to be able to get it through, but there will be things that we'll need to do immediately, and obviously recovery post-COVID is going to be top of the agenda, and we're already beginning to tackle that, but you've only got to kind of read the newspapers and look at the recovery plans to see where that is. The reason why I raise that is not because it's kind of so obvious, it's that in doing that, we must make sure that we've also got an eye to improving the way in which we work whilst delivering the recovery, rather than closing things down and going, I'll do my bit on recovery, then I'll come back up for when it's over, because it's probably going to be a few years before it's over. And we've got to be able to do those two bits at once. Addressing inequalities, that's been really clear from COVID, that we need to really proactively look at those members in our communities that are kind of finding it more difficult to access the services that they need. Place-based partnerships, we've got to get those in quickly and effectively. So not quickly and rushed, but they are a priority. So we can begin to think about plans for Oxfordshire and improving the services that we provide across the piece to residents, the health and care services. Your own membership and your own constituencies are, I think, an important part of that connecting in with the communities, and local authorities want to be doing that, and there are a number of ways which we haven't yet kind of settled, but I would encourage you to keep an open mind about how we can take advantage of those relationships that you have within your communities. And the final point, I think, around these immediate challenges is the need to act and behave as a system. If we wait for all the protocols and all the this, that, and the other before we deign to behave as a system, we've done the wrong thing. And so we've got to start behaving in that way. One of my jobs as chair is to encourage and support the way that we work as a system, and make sure that we don't go back to the top will tell you what to do, because this has really got to be, the bottom has got to help advise our plans. So I hope that those have given you but a bit of feel. I can see lots of hands going, Jonathan, so I shall stop there, but I'm very happy to answer any questions that people have.
Thank you very much, David. And I'm going to start with people who haven't had a chance to ask any questions yet. So Tony, if you don't mind waiting for a little while others have some airtime. Graham, I think you were the next up on your hand.
Thank you very much. Well, thank you, David. I particularly liked what you said at the end, which is let's start from the bottom up and not from the top down, because I think the NHS and the Department of Health have had a habit of telling us what to do for a very long time. And it worries me as a patient that actually we put the patients at the bottom of the list. And really, I would like to see patients at the top of the list. Patients have a better view about what's important to them than anybody else. There's no getting away from that. We can think we know, but actually you need to get out there, and you find surprising things when you do. And you find very important things, particularly when it comes to integrating across the piece, because you start thinking about how is public transport working, how is language working, how are social things working. And I see nothing in the plan, much as I like what you said, which really gets to grips with how we can engage with patients about what is important to them, because that's the future. The future is going to be patient-led. And I would like to hear how you think we should do that.
Graham, before I came anywhere near the NHS, I used to work in retailing, and one of the things I used to do there is insist the organisation drew the organisation chart upside down. So the chief executive was at the bottom of the pyramid, and the stores and the customers were at the top. And philosophically, that's still where I come from. Practically, we're going to have to meld the two processes. And you're right, the NHS has a very top-down habit, as does number 10 Downing Street have a top-down habit. So we'll need to balance the two. But so when I talk about revising care pathways, and all those relatives I've got, or my mother's relatives, who go to one appointment, and of course clinically the appointment's fine, but then suddenly the letter doesn't turn up, or all the kind of complications that come in with that. So there are a number of, the digital program, for those that use it, is going to be helpful. The making sure that we've got carer and patient inputs in the design of how those pathways are delivered is going to be really critical. Otherwise, we'll be terribly pleased with ourselves, and people will still find it difficult to get the best out of it. What we need to do is to make sure we've designed, and it is one of our kind of must-do work streams, but designed a process that gathers together the kind of, I hesitate to say the patient voice, because this is not about kind of professional patients. This is about how you are able to fit into your lives the treatment and care that we can provide, rather than what we're going to do and you can fit around us. And that's quite a difficult mindset change as well. So I'm there emotionally. We will be putting in place mechanisms. I don't think it'll happen overnight, but it should happen to a far greater extent than it does.
Can I just suggest that in thinking about those mechanisms, you do engage with patients heavily, and perhaps you think about, in a case where we've got limited money, would your patient rather do this or that? And again, I would very much like to see some proper study made of this, because again, I think it would be revolutionary in terms of how we organise healthcare and health in general.
David, I'm going to discourage you from answering that, because I know that you're sympathetic to that point of view. Graham, we have a number of people who haven't had a chance to get in, so we'll register that point. And perhaps at the end of all the discussion, David, you might want to sort of draw strands together on a range of things. I'm going to start with the people who haven't yet had a chance to ask or comment. So I'm going to go to Astrid next. It might help David to know when people come, where people come from and who they are, mightn't it? So Astrid, would you just like briefly to introduce yourself?
Sure, yeah. My name is Astrid Schloesscheid. I'm a Provost Chancellor and Dean at Oxford Brookes University, and I'm an appointed governor. I was wondering actually whether you could comment on what role you see the universities play in the system and in the plan development. And the reason I'm asking is that, of course, the delivery of the plan will depend very much on having the right size of workforce and a workforce with the right skills. And I think university probably will play a key role in that. So I wondered whether you could comment on that.
Astrid, yeah, we've obviously been talking to your Vice Chancellor, because I was in a conversation with him, I don't know, 2 weeks ago, I think, and certainly connected him into the people who are leading our workforce development. But it is an interesting issue, because although we all know we have an immediate capacity issue, I think it's a lot to do with, as well, developing new skills, and I've talked about digital health. That's only but one of them. The other thing is to look beyond the kind of hermetic organizational boundaries, to go, I'm one of those there, when you might be one of those, and be able to work across a number of organizations as well. And I think the universities are going to play a really key role in probably twofold, really. One is clearly, obviously, designing the training and making sure it's there, but I think helping us work out how to do that. I mean, I think the kind of research and academic application that we can get from working closely with you and other universities across Bob, I think would be folly not to take it on board. So it can also, coming from the Academic Health Science Network, where we have a lot of connections with universities, it seems to me a very sensible and natural thing to do. So I hope we can produce good stuff together.
Thank you, David. Rosie.
Thank you. I'm coming from the background of being a local councillor, so I've got that background, and you almost make this system sound sensible, except every time I read the reports, I find I'm just reading words, and actually trying to make sense of actually how it's going to work is still seems, you know, a challenge beyond. But there's a few things that seem to be a bit of a problem. If they're replacing CCGs, there were two problems with CCGs. One was public accountability, and the other was the flow of money. And from the experience, say, I was a governor of a mental health trust in Northamptonshire, and the government would make some wonderful announcement of, we're putting in X million into adolescent mental health or whatever, and we'd go to the next meeting and we'd say, well, where is it? And it never arrived because it would get stuck at the CCG, and they were they had the priority to keep the acute services going, which were always funded, and nothing ever came through. So I don't know whether this system will change that or not. And then you did allude briefly to where is the role of the Health and Wellbeing Board, because it almost sounds as if the partnership is replacing the Health and Wellbeing Board. I can't see where the two coexist, and also whether there's a role for overview and scrutiny committees within the local authority. So, thank you,
Rosie. Thank you. There's a good list there. Let me work through that. I mean, the commissioning function that sits in a CCG will come into the ICS, and so the Integrated Care Board will have responsibility for commissioning. But on that board is going to sit providers of what is commissioned. So we first that we move away from this, I'll provide and it's our commission, you provide, and we sort of sit in contractually separate camps. So they'll be in the same room. There will be contracts, of course, but nevertheless they'll be in the same room as that. And what will be commissioned are elements of the plan which have been developed at the partnership board. So where we've got community and health, of course, and local government feeding into this integrated partnership board to develop the overall care strategy, they should see coming out of the commissioned work stuff that we all agreed was going to be important. Now, clearly, there's going to be some national guidance on stroke and cardiology and areas like that. We'd be naive not to expect that, but there will be things that we say in this area we believe that particular attention needs to be paid to whatever it is, and that board will look to the Integrated Care Board and go, well, we all agreed that this was important, and I don't see it in your plans, and I'm not seeing it commissioned, and I want to know what's going on. So I think there will be a stronger link there. With the Health and Wellbeing Board, it is interesting. I mean, I think the Health and Wellbeing Boards are much more relevant to place. So although the work that comes through on the joint strategic needs assessment and all the work that public health will come into Health and Wellbeing Boards in place, and feed up to advise this overall program. Actually, it's when the delegated monies, and quite a lot of the commissioning will be delegated into place too, by the way. It's there where that link between the needs of the local population and the delivery of health and care is really kind of a portion. The funds are a portion where we need to do a lot of stuff on this, and some of it on that will happen on that place-based board. And I think that's where you'll see a much stronger link between the health and wellbeing board. I don't know which council you're in, Rosie, but if you know, the conversations that we were having previously with Oxfordshire and the health and wellbeing board, very, very close on that. And HOSC itself, of course, well, there's a responsibility to make sure that the changes and the scrutiny that needs to be applied will continue. So I hope that the new approach is going to strengthen the accountabilities, but more importantly, kind of stop being the, you know, down the corridor we're doing that, and down this corridor we're doing that, and we hope it kind of marries together. This is meant to be a plan that kind of pulls all the strands together. And year one, it probably won't do it 100%, but that's what we'll be trying to do.
Thanks, David. I've got about half a dozen people coming in, but I think this is something the governors have been wanting to talk about for a while. So with you're happy to carry on, I think we'll keep the conversation. Viv, I wonder if you wanted to pick up on the comment about engagement with the younger age groups and their families.
Yes, hi. I think I just wanted to pick up something that Graham was saying about sort of patients upwards. And one of the things we're looking at through YIPI is how we can engage better with maybe the sort of young adults age range. So particularly looking at the 16 to 25. It feels like it's quite an underrepresented group. So yeah, it's very much in its infancy at the moment. So we're just having sort of very embryonic conversations around it. But yeah, just to put that point in.
No, that's, I mean, it's really interesting, and I suppose if there is any role for the system, it isn't. You'll know how to do that better than we will because you're closer to it. But maybe making sure that we can share best practice. I mean, there might be some people in Devon who've got, you know, doing something clever or whatever. So certainly we need to do that. But the idea of so kind of resource and support, I imagine what you would need. You certainly don't need to be told what to do because you know.
David, can I move on to Helen Heim?
Thank you so much, Chair. David, thank you for your very insightful comments and on the ICS. It's a bit of a novel and interesting area for all of us, I think. But my role is as a consultant anaesthetist in the trust, and I'm an associate professor in the Nuffield Department of Clinical Neurosciences. I'm the university rep on the Council of Governors, and I've just come before I came to this meeting from a meeting at the Chartered Institute of Ergonomics and Human Factors, and you've just been talking to us about a pretty complex system, and I just wonder how much support, advice, input we might be getting from this particular discipline, from systems engineers and ergonomists that could support the implementation of, as I say, what is a very complicated system.
Wow. Do you know, I remember 7 years ago doing a presentation to the board of a foundation trust, not on one of yours, and I was making the point that Amazon know more about the state of their books than sometimes we do the patients in between steps on their journey. And of course, everybody thought I was mad because I'd clearly not been in the NHS long enough. And so that kind of system working is a sort of philosophy, but it also does require a kind of engineering, if you like. So I'm sort of sympathetic to that view, Helen. I guess I don't really know enough about the bits that you're talking about, but if people were to come and say, we think it would be a good idea to kind of think of this in a I kind of suppose a responsible joined up way rather than it would be a good idea if. So it's like how you design this in so that it works well. I would be very willing to listen. I haven't answered your question.
It's good to hear. No, I just think that there's an awful lot of focus on the use of human factors ergonomics for patient safety, which is my particular research interest, but not really. It's an enormous field, and there's not really enough use made of their skills and expertise for this kind of situation in healthcare.
Is it focused in any particular university?
Yeah, Loughborough.
Sorry, where?
Loughborough.
Oh, Loughborough. Oh, well, yes, that is interesting. Because I was looking at something else with them. Yeah, well, let's say yes, it'd be interested, and perhaps we can connect up outside the meeting if you like. Very happy.
Thank you.
Thanks, Helen. David. Sue Willicott.
David, can I commend you for your enthusiasm about this? But I'm very ancient, so ancient that I've actually worked on the 1974 NHS reorganisation. And I'd like to return to something that Graham brought up, which is the patient. Now, I'm a public governor for Buckinghamshire, Gloucestershire and Wiltshire, so obviously this is an area that's particularly interesting to me. And in an area now where patients are having to wait 6 weeks for a telephone conversation with their GP, can you please tell me what is the average patient going to see as a result of this reorganisation? What benefit can I tell people I talk to is going to come out of this to the patient?
Yes. Well, I think that's the killer question, isn't it? Really, because why on earth would we be doing this if there wasn't a benefit coming forward? I would hope that they would see an approach and a system that is designed around them rather than designed around the institutions that deliver it, which is much easier said than done. But it has happened in other places where users of services have been able to, in a sense, recognize, to be able to input to the design of how that service is delivered. So it would be, I mean, there was a comment from, forgotten who it was, Graham, I think, about listening to customers about what the services should be. And I'm also very keen about how services are delivered in a coherent way too. So I would like patients to say, things have changed, things have improved. It looks much more sensible now.
Well, they can't. The problem is they can't say that until they can actually access their GP fairly rapidly. They can be reassured that either they're not very ill, in which case they can take their antibiotic, or if they need to go to hospital, they can get there fairly rapidly. That I feel is the only way that you're going to convince patients that something like this is going to be worth the money, because there will have to be money spent on it. So I'm looking for actual, real benefit. Mm-hmm. And that is the kind of thing, I don't know whether my fellow governors feel the same way, that is the kind of thing that our patients are looking for.
So two things, and I know there's no magic wand here. One is, it may not be that you have to go to the GP to be told those things, because right. They're in short supply. So maybe actually it isn't the GP, but it's somebody. And I suppose the other thing is we are in. It's a bit of a strain at the moment, obviously, with COVID. But that ability to be able to access quickly. I mean, I've got friends who are, I don't suppose they've got major ailments, but they're worrying because they have, got to wait to go forward and see. So, message received, Sue. But I can't at this stage trot out all the kind of new services that you'd like to hear me talk about now, because we still need to work on those. And so, if you can keep badgering in saying we want to do them, that would be really helpful.
I certainly will do that. Thank you very much, David. Thank you.
Thanks, David. There are one or two comments going in the chat which we won't lose, but I've got two people who have got hands up, Tony and Jonathan White. I'll take Tony first, and then I think we probably need to allow David a bit of respite and move back to our formal agenda. Tony.
Thank you, Jonathan. David, I'm also a unitary councillor on Northamptonshire, and my role is to represent Northamptonshire and Warwickshire as a governor. Obviously, it's a very complex area, something that's desperately needed. But in any business case, how do we measure success? How do we hold the NEDs to account? Because how do we know we've delivered what needs to be delivered?
Tony, one of the things that Jonathan and I have talked about and is that when we get a measure, and I'll come back to the measures of system or place performance, it forms part of the trust's reporting suite, so that your own activity within the geography is kind of seen in the context of what's happening overall in the system. I was talking about health outcomes earlier on, and you may have come across the phrase, population health and population health management on all those areas, and it's really trying to find a measure of the state of the residents at given points, particularly where we're trying to look at areas. So a terribly easy one would be the amount of people who smoke. Another area might be to do with childhood obesity. There might be something in the system on mental health in schools. And if it was to do with acute activity within your own trust, then there'll be some hopefully outcome measures, maybe around, I don't know, rehabilitation or the length of time from. And it's dangerous for me to make these up in response to a question, because people will go, well, you said that. But we need to find some outcome measures, as opposed to, as I was saying before, all the input measures, and the ability to be able to make sure that your own activity, which the NEDs are holding the board to account for, is sitting alongside some system reporting as well, so it's given context. So watch this space, because it's an area that Jonathan, I know, is quite keen on, but we haven't worked out exactly how to make it happen yet.
And David, on the simple ones would be bed blocking. Bed blocking because social services haven't sorted out the patient's home.
Well, that's about trying to support making the system work, and if there's stuff that we can do to help the local authority to make that work, then it is something we ought to be involved in. Yes, and we've all got a part to play on that. So it isn't about the guy down the road's problem; it's our problem that we need to help the guy down the road.
Thank you.
So, Tony, I can assure you, I think that we're looking at having a common data set across the ICS, so that we understand the same set of challenges. The performance report that was received at the CCG at the ICS, including the business on Oxfordshire's CCG's figures, came to the Health and Wellbeing Board in the same form. So we're moving towards sharing the issues, but I think David would agree we've got quite a long way to go before we get that right. David, I've got one final question, then I'm going to try and wrap this bit up, and that's Jonathan Wyatt.
There we are. Yes. Can you hear me?
We can hear you, Jonathan.
Yeah.
Okay. Some of the answers have already been given by your answers to the previous question, but I'll still kick this ball. Dame Fiona Caldecott, at my first meeting, there was discussion over what was called stranded and super stranded patients who did not need the intensive hospital care that the John Radcliffe provided. And the super stranded were those who were even more stuck, but they were not considered competent to go home. Now, I've listened intensely to what you've said today, and some of your answers have covered a part of it. And also, this is very good about the top of the pyramid. But if I took a person, a human being, and I call him Joe Soap, and he's been stranded, he's stuck in hospital, who signs his chit to get care from the integrated system? What care does he get, and where does he go until he's well enough to go home?
Thank you, Jonathan. Well, I'm glad it wasn't on genomics, because I was going to be floored by that. This is a really real human issue, isn't it? About our residents who need to have suitable care, and we need to understand how many are, what sort of care they need, and make sure that we have the facilities put in place, so that if, for example, this was something it doesn't have to be raised by the partnership board, which is a lot of my residents get stranded, and they deteriorate, and it's not good. And what are you going to do about it? It's something that the integrated care board would be charged to do, which is across the area there are, I don't know, whatever it is, X number of people who fall into this category, and generally speaking, they have these characteristics. So you need to provide some kind of intermediate care to be able to move them from one to the other. Now, historically, of course, you kind of get into the, well, is this medical care or is it social care, and who pays for it? We have to find a mechanism that focuses on the needs of the individual, and then find a way of being able to provide it, rather than going, well, my budget doesn't cover that. And that's a combination of mindset in the system, actually having the processes designed that enable those things to happen, and then finding the budget processes that mean that people, are not sort of drastically disadvantaged in their organizations by doing the right thing. So that's, for me, would be a really good example, maybe where Graham started the conversation here, which is, so if we listen to the carers and to the patients and go, what are the kind of steps you need to go through, and see if we can't find a way of being able to support that. And we might decide that that group of X number of people are more important, perhaps, than some other areas, and therefore we will devote more resource behind it. Because,
so you will provide a place for Joe Soap so that he can get home in the end, where he doesn't need the intensive care of £1 billion hospital.
I'm not committing to that if you're there, but yeah, that
I'm trying to corner you.
Of course we have to find an appropriate place where they're safe, and that can happen. Yeah. Otherwise,
and that's the purpose of the integrated care system. Part of it. That's part of the purpose of the integrated care system.
One of my
that's good.
For to start with, improving the outcomes for residents and patients. I think that fits very well into that.
Yes. Thank you, David.
So David, we'll let you off in a moment. I will say a few words and then just give you a chance to say a last word if you'd like to sort of pull strands together, but you're not obliged to. But Jonathan, I think we absolutely need to rise to that challenge. In Oxfordshire, we've now created an Oxford Senior Leaders Group, which during the intense period of COVID was meeting weekly just to take stock of what it needed to do to make sure we operated as a system. And that group is made up of leaders of the councils, the county council, the district council, and the city council, the police and crime commissioner. I and David Walker, who's chair of Oxford Health, sit on it. We also have the ambulance service and the local economic partnership to accept the challenge that we have to knit these things together better. It's been agreed that the chairing of that group will rotate. So in the first year, it was led from local government, and I'm chairing on behalf of health as of last Wednesday. And so I think that's our acceptance that this is something that is absolutely our business. I think we're not yet quite clear how the Health and Wellbeing Board will integrate with the ICS, and we have a new chair of the Health and Wellbeing Board, and there's a bit of work to be done, but it's the obvious place to start for the place. And we do know that, as well as David spending time with us today, James Kent has been and is focused on trying to stop this being too much top down. So I think we accept the challenge, Jonathan, but I like David, I'm not sure how quickly we can commit to solving it. David, I'd like to thank you for coming and just give you the chance to make any other observations you want, and then I'll need to get back to the more normal business of the Council of Governors. So, David.
Jonathan, thanks. Well, I've really enjoyed that, and thank you very much for your questions. What's really interesting to me is how a lot to do with patients and residents and how we get their voice and how we help them. A lot to do with sensible ways of kind of working together, and very little to do with the sort of conversations I'm sure I would never have had with you, but 2 years ago when I came in this role, which were very much about, so what's the other person going to do? And there's a real change, which you are reflecting as well, to want to build a system that works and recognizing that, you know, it doesn't happen overnight, but we will be doing our best to address those needs. So, Jonathan, thank you very much. I really enjoyed it.
Thank you, David. You're very welcome. It's a public meeting, so you can stay, but we won't expect you to, so I'm sure you have other things to do as well. Colleagues, may I take us back to the formal agenda? We're only 32 minutes away from supposedly finishing everything, so I'd like to try and push through formal things as quickly as I may. We do need to agree the minutes of the meeting that we held in March. I'm not aware of any amendments coming through, so may I check that we're satisfied that they're accurate?
Agreed.
Thank you. Then we've agreed those. There are no items we're due to report on the action log at this occasion, but we still do have automated number plate recognition, Rosie, on our list at the point where it may be coming back. So we haven't lost it, but it's not coming up for today. There was a matter arising on the business in terms of the Q1 budget and annual planning process, and Jason Dorset, Chief Finance Officer, came to the Performance, Workforce and Finance Committee in May to discuss that. So if we need to discuss it, I suggest we pick it up under the PWF report later. We need to put on the record that following the circulation of the paper by correspondence approval, it's been confirmed that Cecilia would stay in post as lead governor until the next election, and we have later on this agenda a discussion about getting the timing right for that. So there was universal agreement to keeping Cecilia in post while we work that out, but a number of views might need to be explored about the exact timing. It may be we don't resolve those today because it doesn't seem as urgent as some of the other things, but we're absolutely committed to do that. I need to encourage you to fill in the survey on governors' experience and expertise. A number of people have pointed out that we haven't maximised the opportunities we have from the skills and experience around the table. I know that there was a session on the 23rd of June, which I wasn't able to attend, on the engagement with public and members. But I just want to let you know that the plan is that we'll take that into Patient Experience and Membership and Quality Committee at its next meeting on the 23rd of July. And it will come back to the council in due course. And I think Cecilia will pick that up as lead governor's report a little bit later. Now, I think those are all basically housekeeping things. And with your agreement, and if there are any amendments to the minutes, please can they come into the chat, as I think Anne has done. I'd like to take us to an item we need to take a decision on, which is item 7 on the plans for the annual public meeting in September. This is a paper we took at the board also this morning, and I'm hoping, Terry, that you can deal with this fairly quickly. A number of colleagues were at the discussion this morning, but this is about how we plan to hold the annual public meeting virtually in September in the light of all the COVID challenges that are in place. We'll come back to our own meetings a bit later on, but this is the annual meeting. So, Terry, are you able very quickly to summarise why this feels to give us better reach and how we're planning about getting it smooth?
Jonathan, I think you've almost said it all already. We know that we reached a larger number than we normally do when we have it in person. We had 220 people watch it live, and 760 people watched the recording afterwards. That meant we had 980 people who watched it last year, and because of COVID, and we want to make sure that there aren't issues in relation to holding an in-person meeting. We're proposing that it's done virtually. We're not proposing a hybrid event because the technical issues we think will be too problematic. So we're proposing to have a working group to work through all of the issues and to make any further recommendations, which will be approved later by the trust chair. So I'll leave it open to questions now.
Thanks very much, Terry. I have Tony, Sue, Rosie, and Sally Jane, and I'm not sure which of those are new, so I'm going to go down that list, and if it isn't new, just tell me. Tony.
Jonathan, no, it was an old hand, sorry.
Sue, was yours new or old?
No, mine was old, sorry.
Rosie, is yours old?
No, but it was about the previous thing that you sped on from, and it was about the survey that you did of skills, and I filled it in, and now I think I'm not sure whether I've done it right, but I'm raising this for the sake of other people who might be confused too. It was the language that it used about how the medium was have a working knowledge of, and such as clinician or medical things. I thought, well, I've got a working idea of it, but I'm not a clinician, so I don't know. And I filled it in saying I've got a working knowledge. I know what doctors are. I know what the organisation is. I know how they operate and junior doctors and contracts and stuff like that. So do I have a working knowledge, or do I not have a working knowledge because I'm not a clinician? I really didn't understand the terminologies.
Okay, it's one of those, I know every word in the sentence, but I don't necessarily know what it means. Problems, I think. Let's work with that when we see the results, Rosie, because we'll find out whether or not it looks sensible, and we can get clarification if we need it. But we'll suck it and see at this point, and we'll refine it for the next time around when we've got it.
Otherwise, the proposal for the AGM, I think, is great.
Thank you. Sally Jane and then Sally Ann.
Yeah, hello there. I fully support having the public meeting online this year, and it's very interesting that it does attract a lot more people. Those who know me will know I'm going to raise the subject of those members who don't have access to the internet. We're looking a lot at the moment about equality and diversity, how to reach people who are hard to reach. And I'm just wondering what we can put in place to facilitate them. I wondered, first of all, if the members who only receive information in written form will actually receive information about this meeting, and whether it will be advertised in other ways for people to see it's happening. If people have an opportunity to write in or phone in with questions they want to have beforehand. And then will the meeting be available as a DVD to give people who haven't got internet, or will they be facilitated to come to a trust site and watch it on the computer? I'm wondering what we can do to make sure that they are included.
Those are all excellent points, and Terry, I think you'll take them into the working group, will you?
You took the words out of my mouth, Jonathan.
I apologise, I'll be more disciplined. Sally Ann.
Yeah, hi. I'm the newly elected Governor, Terry, just so you know, for the same area as Sally Jane. I agree entirely with what Sally Jane has said about accessibility and encouraging people to attend, but I would wholeheartedly support the approach you're taking. I did think the trick will be to make the content catchy and engaging. And it would also be interesting to know your watch rates and your drop-off rates for people watching the video. And I think if you look at that for last year, you might know, you'll learn what content is of more interest and do more of that next time.
That's a really good suggestion. Again, I'll take that back to the working group and see, whether we can, see when people drop off or come back in. But no, thank you for that suggestion.
Terry, I think that means we have a green light for working on this. what's the mechanism, what's the timetable by which people need to feed ideas into you in order for them to be picked up in the working group?
So I think if you could, within the next couple of weeks, feedback your ideas to either myself or Matt Akid, and we'll make sure that information goes
Terry,
into.
can I suggest that people route things through Neil or Caroline, because they'll have those contact points and they can pass them on, and it stops things falling through the net. So I think if people could let Neil or Caroline know in the next couple of weeks any thoughts, and we'll feed those in. Cecilia, your hand's gone up.
Yes, I just wanted to say to Sally Ann, unfortunately, there are some statutory requirements at the APM that are not necessarily terribly interesting to anybody except executive members. But there is a requirement at what's delivered at that. So I have mentioned that to the working group, just hoping we can keep, because the feedback from the previous meeting was, can we have more stories? And that is being very much taken into account. But as I say, I do, even when I prepare my talk, think, gosh, this is terribly dull and heavy, but I'm obliged to put some of it in.
Yeah, no, I do understand the statutory requirements, Celia, but I still think there are ways of making that interesting.
Absolutely.
Thank you very much. So we'll any further ideas, if they come in via Neil or Caroline, they'll get routed into the working group. I would like, I think, just to defer the timing on the lead governor election at the moment, given the time, because it would be really useful to just get some ideas from people about their thoughts on how we should approach future arrangements for the meeting of the council. And I think that's our priority in terms of finding things out. Neil has drawn together a paper which sort of identifies a number of the principles we might need to take into account. I think when we drafted this paper, we didn't think the third wave of COVID was quite as pressing or as concerning as we now do, as you've heard at the beginning of the meeting. But I think we need to enable the council to talk a little bit about how we should go about deciding what to do in terms of meetings, what needs to be prioritised in terms of moving back to face when it's safe to do so, but also how we go about thinking about our working as a council and the review of committee memberships. Neil, do you have some decisions you have a particular priority on from this that you'd like us to pick up? Because I need to try and keep this to a few minutes, and we should make sure that things you need to know urgently are picked up urgently.
I think, Chair, that the priorities probably would be to see whether people support the idea that a working group might come together to move some of the thinking forward on this, and possibly to see if people would support on the committee side of things, new governors or others who might be interested shadowing the next few meetings of the committees, so that we can move towards looking at renewing those memberships.
Thanks very much, Neil. So could I ask that working group proposal first of all? It seems a very sensible way of going forward, but others may have a different view. I'm seeing nods, Neil, at the moment. Is everybody comfortable with that process? Okay.
Yes.
And similarly, we do need to refresh our committee membership so that new governors have a chance to be involved in things, and we'll need to have a reasonable process for that. And I think it would be a good way into that to enable some shadowing, that people have a sense of what's going on and not keep membership so tight that people can't know what they're letting themselves in for until it's too late. So I think that's what we need, Neil, in terms of agreement from the council. I'm seeing support coming through in the chat and nods.
Yep.
Neil, can the other things be dealt with by correspondence, do we think? You're muting.
Sorry, Chair. Yes, I've just come off mute. Yes, absolutely. I think if people have got sort of comments on the issues that are raised there, then we can feed those in and route them into the working group's discussions.
Okay, so then they come through Neil or Caroline. I think we've agreed this sits with a working group, and thoughts go into that. Okay, I think then that takes us to Cecilia, the Performance, Workforce and Finance Committee report. And I wonder if you, while you have the camera and microphone, you might do the lead governor report as well, and then I'll hand over to Sally Jane for PMQ.
Thank you, Jonathan. Can I apologise to everybody? You haven't got any minutes from the meeting because they're not yet available. They're not yet prepared. So I'll give you a really brief summary. I think that Sarah Randall actually told us quite a lot about various things dealing on the service recovery. And just to catch up with the annual plan submission, our Chief Finance Officer, Jason, presented the Trust contribution to the draft system plan with the final plan due for submission in June. And it was noted that formal sign-off was now at ICS level. The committee noted that there was essentially a block contract, but the elective recovery fund could be earned by the Trust if it performs such above increasing percentage of pre-COVID activity. The committee heard that risks to the plan were the impact of urgent work on elective capacity, the impact of the surge in COVID activity, staffing challenges, and the need for ICS level qualification for the ERP. Update on service recovery. I won't repeat much. Sarah's told us quite a lot, but the committee noted that some specialities remain closed to referrals, ENT and ophthalmology, which is closed for cataracts and maxillofacial. It's noted that other treatment pathways have been put in place for referrals for these patients in all cases. There's a need for planning to ensure that tired staff had time to recover. That was emphasised. The committee heard that data on long waiting patients and prioritizations had been significantly strengthened. It was noticed that significant work had been undertaken on ambulatory pathways, the use of 111 and admission avoidance. Diagnostic weights were improving and a replacement programme for old MRI equipment was in place. We had a really good discussion with the NEDs who attended and the execs. And some work will be taken forward on that. I have very little under lead governor business other than we've just talked about the good session that NHS providers led in terms of member and public engagement. It was in my monthly discussion with the chair and the vice chair, very much felt there was much more to take forward to PMEQ. The areas that was sort of highlighted that I felt we should mention is the effectiveness that we felt that the clinical groups or clinicians going out to various places and meeting up with members. It would be nice if governors could tie into that somehow. The other thing was the APM. It was felt the APM is very much a two-way process. It's not only about the Trust talking to the members. It's a very important point at which the members can talk to the Trust and to ensure that we have sufficient time and adequate measures to allow good questions to be taken. And there's nothing else I think really that I want to do quickly. I would just say we have talked to a Health Watch or we haven't had any issues that they've brought forward to this meeting. That's all. Thank you.
Thank you very much, Cecilia. And I would confirm that we're feeding into the working group on the annual public meeting how we can make it as easy as possible to feed in questions and get some dialogue going, because that was one of the things that was less effective in the annual meeting last year. We took questions in, but we weren't really able to engage in dialogue. We just were able to give what we thought were answers to questions, but we may not have answered them effectively. So that's within the remit of the working group. So can I invite council colleagues to make any comments or questions in relation to either PWFC or the points that Cecilia's made as lead governor? Anita.
I just wonder, this is a question to Cecilia. As somebody living as a governor in North Oxfordshire, I very rarely hear from you as to what you think are, as lead governor, are the big issues which are either being discussed between you and the chair, or which you're focusing on. And I wonder what your policy is with regards to regular communication with governors in your role as lead governor, as to you know, what you're involved in and what you are acting on behalf of all of us.
Thank you, Anita. Yes, I mean, point well made. As you know, once the role of the lead governor was expanded to including agenda, I meet Jonathan and Anne on a monthly basis. This information is communicated through the lead governor's report. Actually, a lot of what I do is actually transmitting stuff to the trust through the chair, which comes to me from various people in my role as lead. There'll be constituents, academics, staff, all sorts of people. And actually, the reason they have approached me is because they wish it to be kept confidential. And I pass it on very much in that way. It's not something I can share with other people.
No, I understand that. I understand that totally. But I think that it would be important for people who are members of the trust, particularly other governors dotted around the county and just outside the county, to know that that is a facility that they can have with you, that communication. It's a matter of how effective we are being at communicating our queries to you and of keeping a picture on what is overall going on.
Yes, I do liaise, obviously I liaise with Neil as well, who takes in all the queries from governors, and I liaise with Sally for any issues that are coming in through PMEQ, and I regularly speak to the staff governors to hear what they're saying, and I just transmit that in one direction. I'm very much the lead governor. I am not the leader of the governor of councils. That is Jonathan's role.
So Cecilia, I guess the process then is that we're clear that we have a regular channel of communication. We're meeting monthly, so all governors should feel able to feed things into you that they want you to raise with myself. We meet also with Anne, so that gives us a senior independent director role, but also her wisdom in terms of continuity with the past. And Neil joins those meetings so that as actions emerge, we're able to agree where they go. The vast majority of things that are not confidential probably end up in the regular communications that Caroline supports me in sending out in terms of updates. So things that people want updates on, we generally try and wrap up into those monthly updates. And as we were saying earlier, we've identified that you need more frequent information on key COVID statistics. So we're looking at how we should do that. So I think that sort of describes the system. Cecilia, is that right?
Yes, indeed. Just to emphasize something I actually omitted to say, but when we have a new members or new governors starting, we do ask for permission for email addresses to be exchanged. At present, we don't have that, to my knowledge, if that's right, Neil. But certainly, I'm very happy for my email to be circulated to all governors, but we can't do that. None of these circulations can happen without receiving full permission.
Yeah, I give my permission as well. Yes, thank you.
Thank you.
Thank you. Essentially, it is how we keep the communication flowing so that governors across the whole patch are in the picture as to the broad issues which are being communicated between the lead governor and the chief exec and the chair, so that they are kept in the picture as to what is happening with the trust overall.
So I think the system for that, Anita, is that the lead governor's report to this meeting gives you an overview flavour. Things that get actioned work their way into the regular communications, which are my responsibility as chair. Cecilia is raising a number of things also which are either confidential or which relate to how we handle business going forward, and they will work their way through, but I don't think it's possible for Cecilia to communicate those more broadly.
Totally understand. Totally understand. Yeah.
Thank you,
Thank you
Victor.
very much. Thank you.
Sally Ann, you have a hand up, but I think it might be an old one. Is that right?
Oh, sorry. Yes, it is. I'll take it down.
Yeah, thank you very much. In which case, I think I hand over to Sally Jane to talk about PEMQ.
Yeah, hello. And those who might not know, PEMQ is the committee that's for patient experience, membership and quality. And at all our meetings, we try to cover all those three aspects. So since our last Council of Governor meetings, we met on May the 28th. And much of that meeting was taken up with discussing the trust quality account for 2021. You might remember that we were all given that by email and given the opportunity to examine it and comment on it before our committee then looked at it. We discussed this with the Chief Nursing Officer, Sam Foster, and the Director of Clinical Improvement, Annie Sykes, who was standing in for Megan Pandit, who was away. So during that session, we were able to raise issues that we, as members of the committee, felt to be a matter of sort of concern or interest, and then also we raised matters that had been brought to our attention by other governors. And I did hopefully reply to governors who individually who did raise issues and telling them what we were told in response to what they said. And in the light of this meeting, one or two details in the report were rewritten to give better clarification, and we noted some areas that our committee will wish to monitor in the coming months. Then Sam Foster gave us an update on patient experience. That included details of the measures that were brought in to help patients during COVID. And she also looked at future work, which will be around areas which include the revised Friends and Family Test, the interpretation and translating services, and a, for want of a better word, audit, which is being carried out at the moment, looking at the state of different patient participation groups. After that, our committee discussed Caroline's report about the latest governor elections, which actually you've recently received, so you've all had a chance to look at that. We meet next week on the Friday, and we're looking forward to the fact that, as always, at our July meeting, we hear back from our young governors, amongst other things.
Thank you very much, Sally Jane. Are there any comments or questions for Sally Jane? Everyone wanted to go home. Sally Jane, thank you very much for that. I'm not aware of any other business for the public meeting, so my proposal is then that we note that the next public meeting of the Council of Governors is scheduled for the 13th of October. We remain hopeful that COVID may have waned a bit, but we won't know yet. Neil's put his hand up, so I've obviously missed something.
Sorry, Chair. Hopefully not a controversial point, but I think we do need the council to formally approve the Constitution.
Oh, thank you. Sorry, I've whipped over. You've done a lot of work on the Constitution. We do need finally to sign it off, and the paper circulates that. Rosie.
Yeah, I mean, I realise that I have a fairly unique problem at the moment, although may not end up being unique, because I think Tony Baggott-Webb could end up in the same problem. I was just going to ask if the wording for the overview and scrutiny could just say, instead of a overview and scrutiny committee, it could say relevant overview and scrutiny committee, because that would leave the door open for us to have a further discussion.
I'm nervous. Neil, did we not leave ourselves flexibility to do this by chair's action in discussion with the relevant committee? Is Susan on the call?
I don't think she is, I'm afraid. I think that's the case, but we probably need to double check the exact wording
So Rosie, can you leave that with us to check?
Okay.
I'm keen that we agree what we have. If we have to come back with a further conversation, we can in principle always amend our constitution at any time, but we shouldn't do it as a lightly. And I believe we covered your point by giving ourselves flexibility from the discussions that Susan took through, and then we can make a case when we know exactly what is going on. Perhaps we can.
Thank you.
Thank you. Now may I, Neil, say that's the end of the public meeting. Thank you for spotting that mistake.
Sorry, Chair, yes, you may indeed.
Okay, thank you. So at this point, the recording of the meeting needs to stop.